The topic is diabetic retinopathy and retinal disorders for general practitioners. Dr. A Salvin has MD ophthalmology and FRCS, and he's a consultant vitreoretinal surgeon. He's the president-elect of the College of Ophthalmologists of Sri Lanka. He's also the immediate past president of the Association of Vitreoretinal Specialists in Sri Lanka, and he is a senior lecturer at the Faculty of Medicine, University of Kelaniya. Over to you, Dr. Salvin.
President and the Council, College of General Practitioners, thank you very much for inviting to share my knowledge with the experience with you. And if I'm going straight away to the talk, diabetic retinopathy, I will discuss a little bit about diabetes retinopathy, and then after that, few more common diseases which are affecting the retina and which you all are facing with management. Well, in the management of diabetic retinopathy, you have a major role because the patients come directly to you. And the managing in this condition, the general practitioner has a key role, especially coordinating with the endocrinologist, nephrologist, and the ophthalmologist. And this should be the real system because the patients actually trust the general practitioners and most of the time communicate with the general practitioner, not going to have facetly on and off to endocrinologists or the eye surgeons, but it has to be regularly referring by the general practitioner. And in addition to that, you can make the patient aware about the diabetic diseases. And if you take the world, this is one of the leading cause of blindness, but main reason is it cannot be prevented because of the late presentation. Even in US, UK, the late presentation of diabetic retinopathy is a challenge. What is diabetic retinopathy actually? It is a disease of the retina caused by microangiopathy due to long-term effect of diabetes leading to progressive damage of the retina and leading to blindness. Most common cause of severe bilateral visual loss is in the working age group is diabetic retinopathy. And it is a microangiopathy primarily affecting the precapillary arterioles, capillaries, and the venules and postcapillary venules. The basic component of damaging process are microvascular occlusion and microvascular leakage. In this, what happens, there are two events that occurs, especially capillary itself become changed and hematological changes. What happens to capillaries? If you go back to your histology in the second MB level, you know the capillaries has got 3 layers, outermost pericytes, and then you have the basement membrane and the endothelium. In diabetes, all these 3 layers are affected. The pericytes degenerate and finally they lose, and basement membrane become thicker, and the endothelium become proliferated, and some of the endothelia will die. And this will initiate leakage of the fluid from the capillaries. And in addition to that, the blood itself changes. The red blood cells become deformed and Rulex formation become more, and increase the plasma viscosity and increase the platelet stickiness and aggregation. Combined with both these, what happens finally, the blood vessels or capillaries become occluded. Once the capillaries are occluded, obviously it will lead to ischemia. Once there is ischemia, the tissue will die, the retina will die. And if you get a retinal infarction, you can see this as cotton wool spots. This is what we see with the ophthalmoscope. If the retina is not completely died, the certain tissues will become ischemic, and that the reaction of the ischemia of the body tissue is to synthesize vascular endothelial growth factor, so to generate new blood vessels. And once the new blood vessel, the vascular endothelial growth factors are released, it will generate new capillaries from the nearby blood vessels. But unfortunately, these blood vessels are not normal and not growing in the direction where it is required. These are abnormal blood vessels which are fragile. Even with shakiness of the eyeball, you can bleed. So therefore, finally, this can lead to vitreous hemorrhages like in this picture, or it can become fibrosed, and finally the fibrous bands become constricted, then the retina become detached, or there can be new blood vessel formation in the front part of the eye, blocking the drainage system in the eye, leading to neovascular glaucoma. And these are worst scenarios. But before that, there are many other clinical features. When you peep into the eye through the ophthalmoscope, you can see. Cotton ball spots, of course, I mentioned what it is. They are necrotized or damaged retina. And microaneurysms, very often you see that earliest signs of diabetic retinopathy is microaneurysms. They appear as tiny dots, and it is a focal saccular dilatation of the capillary walls where pericytes are absent. And these are located in the outer parts of the retina, and they are not on the surface but more deeper tissues. And usually you see these in the posterior pole, not on the periphery initial stage, and more often towards the temporal side or lateral side of the macula. And if you want to see very clearly, you can do an FFA or fundus fluorescein angiogram and see them nicely. And you can see retinal hemorrhages. There are two types, dot and blot hemorrhages, and these are due to rupture of the wall of the capillaries, microaneurysms. And in these are more deeper tissues, therefore they tend to stagnate like tiny dots or blots. But if it is more superficial toward the inner surface of the retina, you can see flame-shaped hemorrhages, and these are arises from the superficial capillary arterioles. What happens? They also rupture and bleed, but because they are more superficial on the nerve fiber layer, the blood tend to arrange or flow on the direction of the nerve fiber layers. That is why you see kind of elongated or flame-shaped hemorrhages. And you will see sometimes hard exudates. These are lipid deposition on the deeper level of the retina, and these are because the lipid leak out from the serum through the capillaries, diseased capillaries, and these reflect either old damage or diabetic retinopathy or maybe even active retinopathy. Usually this occurs, if you see these are circinate pattern or round in shape, circular pattern, because they leak from one central point where a large microaneurysm. And further, if you look at the fundus, you may see some abnormal blood vessels like fronds-like vessels which are lying on the surface of the retina, or the veins. If you see, you can see beaded kind of appearance on the first picture, lower bottom, left-hand side. Those are kind of a beaded appearance. All these can be visualized using your ophthalmoscope, and or sometimes there can be looping like on the middle picture, or sometimes severe segmentation like sausage-like things on the left-hand side picture. These are used to classify sometimes the retinopathy, but you can see these things in using the ophthalmoscope. What are the risk factors for diabetes retinopathy? And if you look at this, hyperglycemia is the uncontrolled blood sugar is the highest, the most important risk factor. And if you get and the duration, if you get a patient with 10 years of after 10 years, 50% of the people will have some sort of diabetes retinopathy, but after 20 years 70%, after 30 years almost 90% of the people you will be able to find some abnormal diabetic retinopathy features. Hypertension and hyperlipidemia add the risk more to the development of the diabetic retinopathy in diabetic patients. And in addition to that, the females are more common. Pregnancy itself is a cause for this diabetic retinopathy. Smoking, obesity, poor metabolic control, and hereditary. When it comes to the hereditary, there are sometimes a smaller percentage of people who have very uncontrolled diabetes more than 30 years, but they will not develop diabetes, but that only a small percentage of people. Well, how do you classify the diabetic retinopathy? There are various classifications, but the commonest classification is early treatment of diabetic retinopathy study classification. Why you need a classification? Just to talk in a common forum what it is, but if you try to remember these things, those are jargons which is not really necessary. But I think what is important is to identify diabetic retinopathy where it is needed for the referrals. But you divide the diabetic retinopathy into non-proliferative diabetic retinopathy where no new blood vessels are formed. Very easy to remember. But there are abnormal blood vessel changes, what I explained to you, but no new blood vessels are forming. So those are called non-proliferative diabetic retinopathy. And then next stage is proliferative diabetic retinopathy. That is, blood vessels are forming, blood vessels are proliferated. Next is diabetes maculopathy. Is where the center of the eye or the macula is affected, like on the lower bottom, the right hand picture. what is your role in management of the diabetic retinopathy, or how you manage the diabetic retinopathy? The most important thing is you have to manage the diabetes well. You have to control the diabetics. That's the gold standard. If you don't control diabetes, whatever the eye surgeon or the other people are doing is not going to be worth. And control the risk factors. You can control the only 4 risk factors mainly: smoking, hypertension, dyslipidemias, control the blood sugar, and in addition to that, you try to change the lifestyle, like what Amila said, do some outdoor activities or exercise. And very important, the regular screening and early detection, rather than it is affected and late presentation, detection is important. In this case, the general practitioner has a major role in referring the patients. Okay, when to refer? If you get a diabetes type 1, you diagnose those people very early. But one important thing is whether it is type 1 or type 2 diabetes, when you get the diabetes, within the first 5 years, nothing will happen to the eye. Therefore, the type 1 diabetes, if you detect, because you detect them early, so you can refer them after even maybe 4 to 5 years later, after 5 years, because you know pretty sure that it is not going to affect in the first 5 years, and you diagnose the type 1 diabetes early. So when you diagnose a patient, you know that it's a very recent onset. But on the other hand, if you did diagnose a type 2 diabetes, by the time you diagnose the diabetes, patient would have had more than even 5 years. Therefore, if it is type 2 diabetes, the general practitioner, either you have to do the screening or you have to refer the patient to the ophthalmologist immediately, not next day, but earlier the better. You cannot delay those patients, because by now the time you diagnose the diabetes, patient may be having already diabetic retinopathy. So regular screening is very important, and the pregnancy. If you get a pregnant lady with diabetes, already diabetes, referral is important, but most of the time presently the VOG is referring the patients. So in the treatment of diabetes, the control of these risk factors are very important. Control the blood sugar, control hypertension and dyslipidemias, and then stop smoking. Well, what is the management of the eye per se? Now, you regularly examination by the ophthalmologist, or even you can do these things. Dilated fundoscopy examination by an experienced general practitioner is not, I mean, it's possible. So sometimes, we get the referrals from well screened patients only from certain GPs. They manage very nicely, and then you can do certain investigations to see the fundus. Among the investigations, I will just go through these things. Color fundus photography. When you take a photograph, you can see here, this is a normal picture. You can see very nicely the central retinal vein, which is the larger blood vessel here, and the central retinal or retinal arterial branches, which are the smaller ones here, and the macula here, this area. So this is a very clear normal fundus. You can take this into photographs and see. Optical coherence tomography, or well known as OCT, this you send an infrared light into the eye and you take ultra microscopic resolution level photograph of the retina with various levels. You can with these pictures you can assess the various levels of the retina, including the photoreceptor level, other ganglion cell layers and all that. So where you can get very clear images and you see in which level the disease is they affect. Now if you see the right picture, the greenish color one below the color photograph, you can see the retina has got kind of a split like because of the affected. But on the left hand side OCT, you can see the very nicely arranged layers of the retina, so there is nothing in that, but here you get the abnormality. And then in addition to that, you can assess very nicely the vasculature by using fundus fluorescein angiography, where you give a fluorescein dye into the eye, into a vein, and then you take the photographs of the eye. You can see the first picture, on the middle picture nicely, the blood vessels are highlighted here. You can assess, but on the left hand side, the right hand side picture, you see there are a lot of tiny dots and whitish dots which indicate the microaneurysm. There is a larger one towards the corner, and that is leaking to all the blood vessels you can see. And if you see the center, there is kind of a dark appearance. That means the blood vessels are already, the capillaries are blocked. They are going to have serious problems with time. So the treatment is either you observe if there is no retinopathy on the early retinopathy, control the blood sugar, and then the treatment is actually by the other than that part, controlling the management of the diabetes. The treatment is by the specialized eye care personnel, and so you can do the laser treatment where you burn the retina, ischemic retina. When you burn the ischemic retina, leaving the center which is important for the vision, you damage the rest of the retina, so that the demand for the blood is less now. Even so, available capillaries, non-blood capillaries will be able to perfuse the center of the retina. So that's the treatment. So FLT means if there is a focal leakage, you will give the laser onto that place, and if it is everywhere, then you can give a pan-retinal photocoagulation where everything ablated or burned using laser except the center. In addition to that, there are now newly available treatment modalities. You can give intravitreal injections against the vascular endothelial growth factors. When you knock down the vascular endothelial growth factors, so that or block the binding of vascular endothelial growth factors to the blood vessels, so that it will not induce a new vessel formation. And steroids can be given. There are slow release steroid implants. These are kind of expensive treatment. One injection costs about almost 100,000. So, but you can give it, and then it's about slowly release the steroid and prevent the inflammation inside there. There is an inflammatory part also in diabetic retinopathy. And finally, in the late stages, you can remove the blood or remove the blood, the fibrovascular membranes by doing surgical treatment. There are a lot of myths about the retinal diabetes retinopathy. One thing, Ayurvedic treatment. There's still so many people, especially young people, comes it after going behind Ayurvedic treatment, thinking that it's going to settle because they are scared of lasers, scared of injections, and then go to Ayurvedic treatments, comes later on totally blind. This is something that actually has a major role for you to prevent that, educate the patients. At least one patient I see every week, very young people, totally blind, irreversibly blind. And laser worsens the other myth. The patient are scared of getting laser. So, I mean, I'm very sure you may have seen patients when the eye surgeon advised to get the laser, they come to you and ask whether the laser is good or bad. So that is why I told you there's a major role for you to educate them. And similarly, injections. And the other thing is when one eye surgeon say laser, they go to the other eye surgeon and ask for topical treatment, eye drops. Those are myths. Okay, that's my diabetic retinopathy. I think I have a few more minutes. So, other common retinal diseases that the GP is challenged to manage. Now, you can see this picture. Now, the patient, I will tell the history and then what's your role. Now, if the patient comes to you, this is a central retinal vein occlusion. A patient comes to you, say, sudden onset, unilateral blind, can't see anything, or very blurry images. When you ask, no pain, but most of the time your patient may be having hypertension, diabetes, old age, smoking. Those are the risk factors to get the blood vessel blocked. What happens? The central retinal vein at the optic disc level become blocked suddenly. And then the artery is continuously pumping blood, therefore a lot of hemorrhages, but the blood cannot be taken away from the eye because of the block. So therefore you see hemorrhages, and the center, and now the retina is ischemic, and as a result the vision is very poor. Very important to see for these patients, because you can manage again blood pressure, dyslipidemias, manage those things, but these patients most of the time we can recover the vision by giving injections into the eye. The retina become reperfused, and new vessel further sequelae which will lead to a lot of complications can be prevented if you send the patient early. So the history is sudden onset painless visual loss. Look into the fundus through the ophthalmoscope, you will see this picture which you will never miss. And this is the other picture. Patient will say sudden onset, quickly, total blindness. Most of the time not even perception of light, or tiny light seen. You can see, when you see, compared to the previous picture, you can see whitish kind of a pale retina, but on the center you see nice dark spot. That's called cherry red spot, where the central retinal artery is occluded. These are usually young people or very old people, where you have to with the CAC6 large tortuous vessel on the either side of the temporal area, where you have to suspect of temporal arteritis. If you miss that patient, in another 1 or 2 days time, maybe even few hours time, the other eye can get affected. So therefore it is, even if the patient comes to you, even before sending to the patient, it is worth doing a C-reactive protein and ESR just to exclude the temporal retinal arteritis, because if you get this patient and if the patient get the other eye involved due to temporal retinal temporal arteritis, it is our mistake, the doctor's mistake, whoever, whether it is a GP or eye surgeon, if you not prevent the other eye getting affected. And these are the other patients. The patient comes and say, I am losing the vision from one side like a screen coming down, and if you go into the history, patient will say, I see a lot of floaters, I saw suddenly lightning like features, and then when you see the fundus, these are the things that you all can see with the ophthalmoscope. You can see this is what you call retinal detachment. You can see the tortuous kind of a retina on the eye. So this is my last slide. You can see here tiny dots light of appearance. Patient will come say, my vision is central vision is blurred, but sides I can see. When I see somebody's face, I can't see the face, but I can see the tummy only. So that is because your central vision is gone, and we are approaching that age now. This is called age-related macular degeneration. Usually it occurs only after 55. So very important at the moment. A small percentage of people we can treat with injections. So you have to refer these patients, not urgent like the previous 2 cases. Okay, with that I can conclude my lecture. I think if you have any questions, you are welcome, if the time permits, madam. Yes.
Thank you, Dr. Salvin, for that informative lecture. Since we are pressed for time, I now invite Dr. Bihan to present a token of appreciation to Dr. Salvin.